which were the more controversial issues, and how did you elaborate those issues in the moving from PDM1 to PDM2?
Well, about controversial issues, one of the surprising things in both PDM1 and PDM2 was how little controversy there was, given that psychoanalysts, if you put a bunch of them together, you put 3 together, you get 10 different opinions. But a couple of the controversial things involved a favorite issue of mine, which is it useful to think in terms of a psychotic level of personality organization? When we did PDM1, some of us wanted to put that in, but Jonathan Shedler and Drew Western were a little bit uncertain about it and advised against it because they thought it was confusing to people who had come to see the word psychotic as meaning schizophrenic or manic psychosis or paranoid psychotic disorder. They thought it would be confusing, and we didn't have any empirical literature to resolve the question. But since then, there has been some empirical work by Robert Bornstein and Robert Gordon showing that clinicians, and not just psychodynamic clinicians, find it very useful to think in terms of there being a psychotic range of personality organization. Because to a clinician, the difference between, for example, the obsessive-compulsive man who's at a neurotic level of organization, who comes in and says, you know, I'm a bit of a control freak and I think my relationships are a little bit deadened by the fact that I have trouble accessing my affect. That kind of a person is easy to help, but then there's the obsessive-compulsive guy who meets exactly the same DSM criteria, but he completely believes in all his obsessions, which are bordering on psychotic delusions. He believes that if you take them away from him, he suffers terrible annihilation anxiety. He's been this way his whole life. He doesn't see there's a problem with this. If you try to do exposure therapy with him too early, you get massive resistance, for example. And one of the problems we face now is that much of the research on specific therapies for specific problems are done with people at the high end of the spectrum. But clinicians mostly deal with people at the lower end of the spectrum. So the cherry-picked subjects of many empirical studies don't represent the actual clinical practice. And if therapists don't have the concept that you can be not schizophrenic, but psychotically organized in the sense of having some problem joining with consensual reality, being very self-referential, using very primitive defenses, having a lot of annihilation anxiety, having some mild thought disorder. If you don't have that category, then you're always going to be demoralized because you're not going to be helping your patients as fast as you think you should, given what the research says should be possible. So I'm glad we have that level now. Another